Hi, I'm Anna, and I'm going to be jumping into the case study with you guys. So we have Mr. C, who is a 62-year-old male, height of 5'9", weighing about 300 pounds, and has a BMI of 44.3. He was admitted into an inpatient rehab facility after suffering a broken leg he sustained during a motor vehicle collision. Mr. C has a history of smoking, poor diet, diabetes, obesity, hypertension, and hyperlipidemia. His home medications include metoprolol, Lipitor, and metformin. He is a Native American, and his diet prior to admission consisted mostly of fried foods and starches and minimum vegetables and fruits. His lifestyle is very sedentary, including his occupation where he is clerical support staff, so he's sitting most of his day. Alright, so Mr. C suffered a broken arm and leg after his motor vehicle collision. During his hospitalization, his team discussed with him that it may be beneficial for him to go to inpatient rehab. So him and his wife followed the advice and get him into a rehab facility. During his stay, he focuses on increased range of motion and his ability to complete his activities of daily living on his own. A week into his therapy, Mr. C begins complaining of epigastric pain that radiates to his scapula following each of his meals. The pain generally lasts about 30 minutes to an hour and then dissipates. The nurse notifies the physician immediately. So the physician orders his vitals, a CBC with differential, liver function panel tests, BMP, an ultrasound. He institutes Protonix for the patient and pain medication, places the patient on MPO status, and institutes IV fluids. So upon that initial assessment, we find that the patient is suffering from right upper quadrant pain. All of his pain is following meals. His labs show no leukocytosis, a normal amylase, lipase, and bilirubin. The right upper quadrant ultrasound that they perform does confirm that the patient has cholelithiasis without any findings of cholecystitis, and all of the patient's vitals are within normal limits. So our nursing interventions are going to include assessing the patient for the risk factors that may cause the patient to have gallstones. We want to educate the patient on diet changes that could be beneficial for helping them to prevent more gallstones in the future. We want to encourage the patient, once he is off MPO status, to increase his fluid intake. And while he is on the MPO status, we want to make sure that we're giving him the fluids ordered by the doctor. We also want to administer pain medication as needed when the patient is having flare-ups. So let's ask ourselves a couple questions. First off, what lifestyle habits put Mr. C at risk for his gallstones? Well, Mr. C has a diet high in fat. He's obese. He's a Native American, which are at higher risk. He has diabetes, his hypertension, and his hyperlipidemia. He's also very sedentary. So, since diet is so important with gallstones, what changes could Mr. C make that may prevent further gallstones in the future? So a few of the changes that Mr. C needs to include are limiting his foods high in fat and sugar. He needs to increase his vegetable and fruit intake, definitely increase his fiber, and increase his fluid intake. So who is at higher risk for cholelithiasis? Studies have shown that females, Native Americans, Mexican Americans, pregnant women, diabetics, and anyone over the age of 60 is shown to have a higher risk of cholelithiasis. So let's just take a quick look at the patho for gallstones. So gallstones, like Shatina had said before, are hardened deposits of digested fluid that form in your gallbladder. And as you can see in the photo, the gallbladder is that small pear-shaped organ on the right side, just beneath your liver. It holds a digested fluid called bile that gets released into your intestines. And so you can see in the duct there that if these deposits are formed, it can cause a complete blockage in that common bile duct, which is generally where the pain comes from.